Live. This is Dr. Michael Kaye from the Center for Functional Health. And once again, I'm glad to speak with Pam. Pam, you're kind enough for coming back. When we first spoke, we had this horrible feedback issue. So thank you again for spending some time with us. So for those of you listening to us for the first time and missed our first time, Pam, if you can tell us like your hero's journey, right? How did you get here? Let's talk about your background first. We'll set the story and then we'll move forward.
Yeah. And thanks so much for having me again. Glad to be here, glad to be talking about these topics that are obviously very important. So about me. I have now been in the field for probably about, I don't know exactly, 17, 18 years at this point. This was an interest area that sort of evolved through time for me. So I grew up, in a family of a lot of medical professionals. So my mom was a nurse, my aunt was a nurse, my grandmother, et cetera. So I think from a young age, I was used to that profession. And so I was always like, I want to be a nurse. I want to help people. I saw, how my family members felt after being able to help other people. So I think that desire to help people was something I developed from a very young age. And then through time and through some sort of life experiences, I started to feel like, maybe therapy is actually the area, that I want to be in, and so I was always sort of that friend who people would turn to for advice or suggestions, or, they would say, you're a good listener. And so I was like, okay, I really liked those compliments, and, went through some personal stuff where my brother had an addiction, at a young age, and just sort of seeing how all of that kind of unraveled, and, so many different professionals were working with him, from a mental health perspective, that I was really thinking, like this is such an important area, mental health, and physical health absolutely is as well. But I think through my life experiences, I was like, I think this is where I want to be. I want to help people, who are struggling with any type of mental health issue, and then through time, I kind of developed specialty areas. So like, I like to specifically work with, eating disorders. I like to work with anxiety, relationship problems, OCD, stuff like that. So I think through time, that's just sort of evolved. And that's sort of where I'm at now.
Gotcha. So you're a licensed professional counselor,
Yes.
and you're a certified clinical trauma professional as well. So can we
Yes.
talk about what's the difference between like a licensed professional counselor, and somebody who goes to a psychologist? Where do you work as an integrative model? And then we can talk about, the certified clinical trauma professional designation.
Yeah, sure. So in the state of Pennsylvania, like you said, it's licensed professional counselor, LPC. In other states, it might be titled something slightly different. But basically what an LPC is I've completed my master's program, and then I have accumulated experience in the way of, we consider it direct and non-direct clinical hours. And once that is completed, you can sit for a state exam to become an LPC. So basically an LPC, if you think of it this way, is between a master's level, between a master's and a doctorate. It's like right sort of in the middle there. LPCs mainly work with clients. A lot of the times, psychologists or people who go for a doctoral degree, a lot of them end up in academia, in teaching and stuff like that. But they're really, other than that, other than the ability to teach, there's really no big difference clinically between an LPC and somebody with a doctorate, other than, some more experience, I would say, but an LPC can have their own practice, they can bill insurance, all of that type of stuff. So, in the mental health field, it's kind of almost a necessity at this point, that if you want to see clients and you want to sort of have a little bit more flexibility in your career, a license is really kind of needed at this point. So that's that. And then, in our field, I just spoke about specialties and sort of, interest areas and all of that. One of my interest areas is trauma, because I feel like, I just hear about it all the time at every different place that I've worked. It's been, something that I've dealt with consistently. So, in our field, you're able to sort of take trainings, extensive trainings, and then you can sort of get certified in different areas. So that basically means that you have more experience. You've learned a little bit more about a topic than you typically get in your education. And that's what I decided to do with trauma. So to pursue a certification, that lets people know, like, yes, I've had additional training in this area, and it's something that I feel comfortable working with.
Gotcha. So let's talk a little bit about trauma, because we're hearing that more, and thankfully so, right? So I think a lot of people had trauma and didn't understand that it was trauma that they underwent, received, experienced. So if we can talk a little bit about trauma, that it's more than, it's not so much physical trauma, it's this emotional trauma, and something may have occurred when we were very young, and now later on it's comes out as a physiological symptom, right? So we'll see that with like a lot of our IBS patients, because we treat
Yeah.
a lot of irritable bowel patients, a lot of gastrointestinal dysfunction, and sometimes the disease course itself or the clinical presentation itself is traumatic. So we want to, look at it from that perspective. But I think a lot of people don't recognize that there's often a relationship between food and trauma as well, and the way
Yes.
we approach food. I remember my sister was very overweight when growing up. My father would say, "Hey, for every pound you lose, I'll give you $5." And even as a young kid, even before I got into this whole, the medical world, it was kind of like, man, something's just funky about that whole thing, right? I mean, that's just an oddball reward system, right? I'm going to give you money for weight loss. Now, I understand his intention. His intention wasn't malintent. His hope was for, motivation. Maybe this would motivate her. But obviously, it was not a motivation. And sometimes we have to be appreciative of the economics. We could be in a large store where, a young kid, a child who's 8, 9, 10, who's already overweight, says to mom or dad, "Hey, I want to buy these shoes." And they're like, "We can't afford these shoes, but I can get you this candy bar."
Yeah.
Right? So we have to be appreciative of the economic aspect of food as well. We'll
Yeah.
dive deeper in that. So when we talk about trauma and food, it's so interrelated. So in your experience, what do you see with respect to trauma and how one chooses to eat or not eat?
Yeah. Yeah. It's a great sort of place to start. So many of the clients I've worked with eating disorders or symptoms of eating disorders have a trauma history. The connection is there. And what I can say is that food is used for these particular people as a way of coping with their emotions, basically. So they're feeling overwhelmed. They feel out of control. They feel some sort of overwhelming emotion that they're having trouble coping with. They will use food to sort of manipulate how they feel. So these people are actually using food to kind of make themselves feel better. So if you think of like binge eating disorder, like that is classic in terms of a lot of people can make the connection that I turn to food when I'm really upset about something. Or you'll hear this, the story is, this is all over social media and all over everything. Like, the person who breaks up with somebody and then they go out and eat a carton of ice cream. It has become this thing that the media or whomever puts out there, that this is what you do to deal with an emotion that's overwhelming. And now it's also the same for anorexia, right? So you're restricting food, and that is actually you're training yourself that restricting the food is the positive experience. So those individuals are experiencing some sort of overwhelming emotions that they're having trouble controlling. So they control their food. So I'm not going to eat these things. I'm going to not eat for the rest of the day, and they're getting a reward. They're basically feeling like that's a reward, and they're seeing themselves perhaps lose weight. And so that is, again, a sense of accomplishment, a reward for them. So, traumatic experiences happen to these people, and then they're having such trouble regulating their emotions that they're manipulating food in some way to sort of feel better, really.
Yeah, nobody has a bad day or a breakup and then say, "Hey, let's go get a 6-pack of kimchi."
Right.
Right? And that doesn't happen, right? So we like to say, dessert spells backwards is stress, right? You,
Right.
you don't come home, horrible day at work, I need a couple of heads of cauliflower, right?
Right.
So they get that reward, but unfortunately, that reward can also set up other type of disorders and dysfunctions,
Right.
right? So we see that a lot. In what you see, can we go through like the eating disorders that are out there? And I were briefly discussing like what's been happening, what we're seeing with these Instagram influencers, who unfortunately I think it was half a dozen people, 6 women recently passed away. So I want to touch base on that and provide especially our young people with some tools that they can look at that and decipher, hey, you know what, this is not healthy.
Right.
Now, for the most part, we're used to seeing this in a female population, but you know what? From a male population, we're starting to see that as well too, right? So if we don't look like
Yeah.
X, if we don't look like a certain way, if we're not this big muscle guy, if we don't have these ripped abs, she doesn't want us, right?
Right.
Or he doesn't want us, right? So you also know, like, all right, so we got to look good and we got to make a lot of money, and that's how we're going to do it, and that's how we're going to get that person that we want to want us.
Yeah. Yeah.
But that's not a healthy way to go. So the one I think most people are familiar with, if we can talk about anorexia and bulimia.
Sure. So anorexia, as I was just explaining a little bit, but to lay it out a little bit more, anorexia is the restriction of food. So it is cutting out, it could be cutting out food groups, cutting out things that are considered unhealthy or whatnot. But basically, somebody is restricting their food intake. And, to have an anorexia diagnosis, you have to have significant weight loss. So in the previous DSM, which is the Diagnostic Statistical Manual, for mental health disorders, previously there was like you had to lose a certain percentage, of your weight or whatnot. They've revised that to just basically be a little bit more subjective, but the criteria is significant weight loss. So basically, that's what anorexia is reducing your food intake to the point where you are losing a lot of weight. Also, in anorexia, there's a ton of health conditions, and that's why a lot of individuals suffer serious health problems because of it. Because again, you're not taking in the nutrients that your body needs, and so what happens is your organs start to shut down, specifically your heart. We see with anorexic patients often very low heart rates. We're talking like could be in the 30s, 40s, which is problematic because if it's in the 30s and 40s while you're awake, it's dropping much more when you're sleeping. So obviously a huge concern. So to move on from that, bulimia is eating an excessive amount of food and then finding some way to purge that food. So that could be through vomiting. It could be through excessive use of laxatives, diuretics. It could be exercise, which again is I feel like that one, is a big one these days, and exercise in general, like we were just talking about with social media and how, we see all of these fit people, and that's what floods our Instagram feeds and stuff like that. But what happens again with bulimia is, you're eating an excessive amount and then you're finding some way to get rid of that food. So you have the urges to eat the food, and then you've got those urges to sort of get rid of the food in some way. Now, again, a ton of health issues with that as well, because, specifically with vomiting, or really any of them, actually, you've got issues with your esophagus, or, you'll see people who, lose their teeth, because of it. It's really scary stuff, because, putting something into your body and then you're trying to get it immediately out, so that obviously that's, very taxing on your body, so those are the two main ones. There's a lot of other eating disorders out there, specifically orthorexia, which is basically, concerned with eating healthy, so that's there. There's also what's called avoidant restrictive intake of food, ARFID, ARFID. That's pretty much cutting out certain foods a lot of the times because you can't tolerate the texture or the feeling of it in your mouth while you're eating it. So that's a relatively newer diagnosis in terms of an eating disorder. And then there's sort of also this umbrella eating disorders that don't quite fit into one of the other categories. So other specified feeding or eating disorders is what it's sort of the umbrella term. So that would be someone maybe who restricts their diet, but is not losing weight. That would be a good example of it. Doesn't quite meet the anorexia criteria, but there's definitely some issues here, with the way that this person is or is not consuming food.
So I want to add to the other physiological issues that occur while is also bone loss, right? So it affects bone as well. When we start restricting protein, we see a lot of physiological issues. These eating disorders also bring about immune deficiencies as well. So you're not as strong. You lose your immune resiliency is what you lose as well. So there's more to it than this person just losing weight. I think that's important to really take a look at when you're seeing these type of people. So one of the questions I get when a patient comes in is like, can I be cured of fill in the blank, right? So in your opinion and your experience, can somebody be cured of an eating disorder?
It's a great question.
It depends. I get that.
Yeah.
And there's nuance, but can somebody be cured with the right help?
Yeah. I like to use I think with this stuff, when you've had an eating disorder, you will always be in recovery. Like that's sort of how I talk with people about it. So can you be actively not using your disorder? Absolutely. So if you want to kind of consider that a cure, yeah. However, like if we think about this, recovering from an eating disorder is so hard because you need food to live. And if your problem is with food, then it's literally something that you have to deal with for the rest of your life. It's developing that healthy relationship. It's not like a substance, right? Where, okay, if I don't use pills or I don't have alcohol, like you can just cut that thing out. You can cut that out completely. Like food, you can't cut out completely. So it's different in terms of sort of an addiction. But what I can say is, yeah, I've worked with patients who had eating disorders for, it doesn't matter how long, but were able to successfully recover and to this day are doing fine. So yeah, I think you can consider it a cure, but you also have to be careful in understanding that it is something that you have to face every single day. So it's not something you can choose to ignore. It's something that you do have to continue to work on.
Yeah, it's like I always think like everybody needs to exercise in some form every day, right?
Right.
If somebody has hypertension, they take an antihypertensive medicine, they don't even think about it. But I think when there's food issues, it's always top of mind because wherever we go, my gosh, it's there, right? So somebody has a baby, we're celebrating with food, right? Somebody loses a job, hey, well, let me take you out to dinner.
Right.
It's a bad day, we're going to eat something. It's it's football time, we're going to get our snacks for the day. So you can't seem to escape it. You can't say to somebody, or you can, but it's hard to say, hey, let's meet and we'll go to the library and chat for a while. Oh, we'll get something to eat. And we're back to food again. Or, they'll get a coffee. And yes, you can get a black coffee, but it seems like it's always, in our face. So I agree, as an addiction, we don't need cigarettes, but we do need food.
Right.
So what kind of tools can you share to say, okay, if you are suffering with this anorexia or bulimia, and are the tools different, and we're going out to eat or there's going to be a party, how do we deal with that?
Yeah, I think one of the biggest things sort of with recovery from eating disorders is having the support around you, because a lot of the times it's hard for you to do it on your own at first, like, you know, because you have to sort of follow a meal plan, and if you've got some support, then you have somebody kind of holding you accountable, or something like that. So I think, when we're approaching this stuff, having that support system of people that you can talk to, and people that can sort of have their, I hate to say it like this, but have their eye on you. Like, it's important. It's important to have that person that can hold you accountable, for what you're doing. Now, like I said, I think one of the biggest things is determining what's best for you. For some people, it's, maybe you don't need that scale in your house. Maybe that is more problematic than it actually is helping you. So you kind of have to take those little things and say, okay, is this helping my recovery? Is this hurting it? And do I really need this thing? Right. And so, do I really need this app on my phone that counts my calories? Is that really something that is going to benefit me? So I think when it comes to that, you really have to weigh what you allow in your house, what you use, social media, like cutting down on, those pages out there that feature almost this like unattainable reality, like, is that something that's healthy for me? So I think you've really got to take a ton of things in your life and determine, if I'm struggling with an eating disorder, or if I'm in recovery from one, these are things that may not be helpful, and I need to sort of cut them out of my life so that, I'm not tempted with them. I'm not tempted to weigh myself 20 times a day, or before and after I eat, or before and after I exercise, or something like that. So, I think that's just sort of an initial tip, is to take a look at the things that you're doing on a regular basis, and, getting rid of them if they're not helpful.
Yeah, and we talk about like what we see. I don't remember the Arnold Schwarzenegger movie? It was the Terminator.
Yeah.
Remember that? And Linda Hamilton, and she was in the first one and the second one. So she comes back in the second one, and she is jacked. I mean, looks phenomenal. She's ripped. She's strong. I heard her being interviewed by two DJs when I was living in California, and they said, man, you look amazing. How'd you do this? And she's like, this is so easy. She goes, if anybody follows my plan, anybody can do this. All they need is to have a chef, a nutritionist, someone making their food, somebody picking up the kids, somebody doing the laundry, somebody watching her work out 2 to 3 times per day. Of course it can't be that. And she was
Yeah.
being snarky in her reply. And they're like, are you going to stay on this regimen? She's like, hell no. So, we got to understand, a lot of times what we see is it may be the result of very, 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 very hard work.
Yes.
I mean, some people put in time. There are some people that I say, like, I know these people are extremely strong, but they didn't do a 15-minute workout.
Right.
So I think, we need to take a look at that and say, we have to separate, okay, this is what my reality is, right?
Yes.
And their support system is going to be way different than my support system. And you talk about getting rid of those things that are not supportive. My question to you is this: what happens if that's a family member? Because often it's a family member that, like, this is the person that's dragging me down.
Yeah. Yeah. And that's why in eating disorder treatment, it is, to me, almost vital to have some sort of family therapy, some sort of involvement with the people in your life that are going to see you every day, and potentially, like I said, be that accountability system and support system. It's not just, I'm holding you accountable for all the bad choices you might be making, but also pointing out the positive stuff that you're doing. So, I think family therapy really works on that. Really, a lot of people are not educated about nutrition, are not educated about what an eating disorder does. They just think, oh, well, this person chooses not to eat food and thus they become thin. And in our society, thin is good. So no big deal, right? So a lot of people are just, they just don't know that like eating disorders can and will kill you if you do enough damage to your body. So that's the first thing that I would say is that you need to get your supports involved in your treatment to some degree, whether it's consultation, whether it's having family sessions, something like that. I think that's vital, first of all. I also think too that if your support system is not your family, that's okay too. Like, who can you reach out to? Who can maybe become a little bit more involved in your life? Extended family, friends, significant other. Like if you can't escape maybe a family member who is not looking out for you or doesn't have your best interest in mind, then it's a necessity to find somebody else. Like find someone else that you can talk to about your emotions. Like again, we go back to this, the eating disorder is a behavior to cope with overwhelming emotions. So you need somebody supportive to talk about the emotions, and find alternatives of ways that you can handle, your emotions rather than turning to the food. So, find somebody supportive. There's also groups out there. There's virtual groups, there's support groups, there's, all kinds of stuff out there that even somebody who feels like there's absolutely nobody out there, there is, and you can Google sort of support groups for eating disorders, and you'll find some stuff out there. So, that would sort of be my answer there, explore therapy with that person first. And if that person can't be healthy for you, find someone else, and there are resources out there for people.
We had to have some of our patients tell their significant others, thank you for bringing the Danish, the good breads and all that stuff that tastes very great. They're buying it because they feel it makes them happy, but then in the end, it's really like destroying their system. So they had to have that very frank conversation. Thank you, but there are other ways for me to have pleasure.
Yes.
So I always feel that with convenience comes consequences. And I think because how easy it is to get food, as opposed to before, it always wasn't easy to get food. We go for those hyper palatable foods, and it's just something simple, easy, and we have a couple bucks in our pocket, but the nutrient value is very low, right? So how do we get this patient and this client to understand that when we walk into, let's say, a Wawa, and we can make a really lousy choice and we can make, a better choice. It's not going to be 100% organic and blah, blah, blah. I get all that, but we can make a better choice. So often patients will like, oh, I was already there. So what can we do and say to them and direct them, like make the better choice? Like there's a reward for the negative choice, the taste. So what is the reward for the positive choice? And apparently when I tell them, oh, you won't get diabetes, you won't have any amputations, you won't have hypertension, apparently that's not a good enough reward, right?
Yeah.
So what is that I could share with someone and say, okay, here's the reward.
Yeah, because the thing is it's so impulse driven, it's like people start to have this urge for something again that's, considered pretty unhealthy. So it starts with the urge, and that's what I like to work with a lot of people on is, let's get to this before you get to Wawa, right? Like, let's get to this. The second that your brain starts thinking, all right, I need, a burrito with all the things in it and, something significantly unhealthy, or I need to go to a fast food chain, right? So I like to get to people before that happens, because if you can then sort of, I use the word distract, but do something else when you're having the urge, then typically that urge will reduce through time, right? So, if I'm thinking about, I need this fast food item, and instead I decide to call somebody, and talk about something completely unrelated. If I go outside, take a walk, if I get out in nature and sort of do something else, do anything else, then typically people say that the urge then just sort of dissipates through time. So that's kind of best case scenario, is catching it before it happens. Now again, if you're in Wawa and you've sort of, not sort of intervened beforehand, then it's about too, like, what can you now do in the store? Like, can you call somebody and say, hey, like, I'm here, I'm having the urge to do this or to buy that. Like lean on other people, reach out, get the support. Like, just because you've made it to the store doesn't mean you failed yet, right? And even if you get something unhealthy, it also doesn't necessarily mean you failed, right? Because everybody kind of, you're allowed to have that. It's just, again, if it becomes a pattern, then that's where there's the issue.
Right. It's like we do a lot of journaling. So a lot of patients say, I got this and I felt guilty. I'm like, I don't do guilty.
Yeah.
We don't do any. We leave guilt at the door because that emotion does not move the clinical needle forward at all. Right. So there's no guilt. It's like, okay, it wasn't a great choice. Make a better choice next time.
Yeah.
Yeah. So it's very interesting. So the one thing I want to talk about though is what I do, and we have some of our patients have this, is this night eating, right? So they get up at nighttime. Oh, I can't sleep. Now I can figure out why they're getting up. And it's like, now I'm up, I'm going to eat. And again, they're not putting together like a salad with fresh sardines or anything, right?
Right.
You're going for that very easy thing. And I'm like, how did that easy thing get into the house to begin with? Because I always figure if it doesn't get in the house and we can prep our food and we can cook our food, we're usually better off.
Yes.
The problem is a lot of people don't cook or don't know how to cook.
Yeah.
That's an issue. And you can still cook something very healthy and still overeat it though, right? So that's the whole thing. So you can be healthy, eat the quote unquote healthy food, overeat that, and then you force yourself to vomit. So we're back to that bulimia situation again, right? So where do we find that balance of like, okay, we need to eat healthy. We don't want to eat this night eating, and we also don't want to throw up.
Yeah. The night eating thing is really interesting, and I've talked throughout this about how really the eating issue is a result of the way that you feel. So it gets interesting. Like, are you waking up in the middle of the night and you're feeling frustrated with yourself because you can't fall asleep? Or, like, what's going on? Are you anxious about something happening tomorrow? Is that why you're waking up? So we have to dive a little deeper there to kind of figure out what's going on, because, if you're asleep and then you just wake up, it's hard to figure out, like, okay, like, what's the antecedent? Like, what is sort of causing this? It's a little bit harder. It could have been, it could have been a nightmare for all you know, it could have been anything. So, I think that, again, I would treat that the same way of like, okay, you're up, at 3:00 in the morning, rather than going down to the kitchen, like, what can you do that's productive otherwise? Like, is there something else that you could be doing? Could you distract yourself for enough time that eventually you're like, okay, I don't need those chips downstairs, or I don't need, whatever it is that you're kind of craving in that moment, like, put some time in between, what's going on here. So, you can do something productive at 3 a.m., or, you could be eating these large quantities of food, which just don't help you. So that's, what I would say, like, find something else to do that's productive in that time if you're awake. I mean, obviously try to go back to sleep first, do some deep breathing, do like a meditation, do some mindfulness stuff. There's so many apps out there that are specifically geared towards, like, if you're having trouble sleeping, like, try to do that first. If you're up, try to do something productive. Like, again, we don't want to get to the part where you feel the guilt, so come up with a list beforehand. Okay, if I can't sleep tomorrow and, or whatever, I can't sleep tonight. Like, these are the things that I could do. Maybe I could, throw some laundry in. Maybe I could do XYZ. Could be anything. But again, it's all about choices. It's all about, what are you going to do? Choose to eat, choose something to be productive that you're going to feel good about afterwards. And sometimes it's hard for people to think that far ahead. Like you were saying before, like, this could give me diabetes. People aren't thinking about that because it's so impulse driven. It's so, I want to do this thing now, so I'm going to do it, and yeah, I logically know that I could get this disease or I could die from this, but like, that's not my immediate reality. So I'm not going to even give it any value.
And they don't, right?
Right.
And to me, it's like, I think, you amputate a limb. I mean, is that not enough to motivate? But you're right. It's not the immediate. And then sometimes another thought process, well, you know what? There's medicine, right?
Yeah.
My uncle so-and-so, he lived for years and he was a diabetic. And he may have lived for years. We have people living for years on meds. But that's not the goal. The goal is to live optimally, right? So
Right.
you want to live to 80, taking a whole bunch of meds? Do you want to live to 90 feeling great?
Right.
That's how we kind of look at it. So there's two other eating disorders I want to talk about. You say pica, right? Pica or pica, right?
Yeah, pica or pica. Yep.
If we can talk about that. And as I said, there's people that have, especially say more in our female clients than our male clients, where they're ruminating at night and are always waking up and stuff like that. But then there's the actual food disorder where it's rumination, like where you eat a little bit and then you kind of get it out, kind of deal. Now that's different than a bulimia, correct?
Right.
Right. We can talk about that.
Yeah, I also want to bring up in that context. Well, let me start here. So there's also a lot of what's called food rituals that people do. And the one that just came to my mind because you were talking about sort of this rumination is a lot of people with eating disorders or just whatever disordered eating will do chewing and spitting. So they'll actually chew the food to the point, they'll chew the food and then they'll actually just spit it out. So then basically they've got the taste of the food, but they're not actually consuming it. So that's a big thing that people with eating disorders do. There's other food rituals like, the food has to look a certain way. Like if it's a piece of chicken and it's not brown enough, then they won't eat it, or it has to be cut in a certain way. Or sometimes OCD symptoms come into it of, I need to cut this thing into 8 pieces. And if it's not 8 and if they're not the right size, then I won't eat them. So there's a lot of these so-called food rituals, like things that you have to do with your food in order to either eat it or tolerate it and stuff like that, that again, may not, some people might do chewing and spitting, but they don't actually have an eating disorder. So it's a really interesting thing, but there's a lot of kind of different things that people do with their food that should still be a concern though. So to go back to your other point, so talking about pica, so that's basically eating things that are not food in a nutshell. So, I've heard of people like crumpling up paper, eating paper, or, again, just insert here, it could be anything, and they're having this urge to eat something and it's not actually food. So that's a really interesting one. Trying to think what else, if there's anything else we sort of missed.
I remember growing up, there was that one kid who ate paste.
Yeah.
You're like, oh no, it's really ate. You remember it? Like the paste, the hard paste, right? It's like you're eating, even back then, like, well, that's a.
Yeah. It's a really it's an interesting one because it's like you kind of think like, how could this person tolerate eating that? But again, it's they're getting some sort of gain. Their reward system is going off here based on something that they're consuming, right? And so then it almost becomes an addiction. Like, I want to eat this thing and I'm addicted to this thing. And it's not even necessarily about taste. It's just the action of doing it.
So when we're talking about rumination, we're talking about that individual who's like, I'm gonna have to cut the foods and X size shape has to, it has to be only 8 pieces. Clinically, and it fascinates me. How does this start? It has something triggers it, right? Because the majority of us don't have it, and a lot of people, we have to be fair. I'm sure there's quite a few people that suffer with this.
Yeah.
But what is the trigger, right? Something has to start that because that's not a typical behavior that we would see.
Right. And usually you see it as some sort of trauma surrounding food in their history. So, maybe when they were young, sitting at the table at dinner, if that was a triggering environment where maybe as a young kid, like your parents were arguing over dinner all the time and stuff like that. And like, you're sort of there just sort of cowering as all of this stuff is happening around you. Then maybe you started to cut your food into these pieces, right? As like a relaxing, this is what this is what I'm trying to do to cope in this situation. Like that's where some of these things are sort of coming from, is like, there must maybe have been some traumatic situation in this person's history that has made that a coping skill of theirs. That's usually what I trace it back to. And that's usually what you find out, that there was something that happened, and this person engaged in this behavior and somehow it made them feel better. So they've just then carried it through their adult life. And that's just now a scary thing to remove. It's a scary thing to remove a coping skill. And then what are you left with, right? Which, is the thing with eating disorders. Like, you can't just strip it away. You have to replace it with something that actually works for that person. Otherwise, oftentimes they just bounce from one addiction to the next. Like, we see it so often of somebody had an eating disorder and then they recovered and they're in recovery for that, but now they started drinking. And, then maybe they go to rehab, they're in recovery for that. And then they start over exercising. And it just runs the gamut there. If you're not replacing this major coping skill with something adaptive, then it tends to jump to another thing.
Yeah, I did a presentation years ago at a gastric bypass convention. And I had the opportunity to sit in with people that had it 6 months ago, 12 months ago, a year and a half ago, that kind. And you really listen to their stories. And maybe at best they had like two, psych intake sessions, and that was it. And what we saw is like, so many of them did really well. Some lost weight, gained the weight back, but a lot of times they lost weight and they just moved the addiction to food over to gambling, over to sex, over to shopping, over to exercise, and never really dealt with that original insult issue addiction first. So we did see it. So I can see where you take away that cope mechanism, something else has to take its place.
Right.
So in a case like that, when somebody comes to you, I mean, you figure out what's going on. Do you then say, okay, we're going to sit here and we're going to cut your food differently? How do you handle that? Do you say, look, you cut your food, it was only in 4, it's not 8, the world didn't come to an end?
Yes.
I mean, that can be very traumatic, that itself. So how do you, as a therapist, introduce, like, how are you going to treat them and not crush them?
Yeah, it's a really good point to talk about, because when it gets to like really serious eating disorders, we're talking when somebody's no longer in outpatient, they're in a facility maybe, or a higher level of care program. You're doing just that. There's a thing called coached meals, like where a therapist is sitting with, a client and basically is kind of coaching them through it, and coaching in terms of like, tell me what you're thinking right now. Let's sort of process that. Let's talk about that. Let's challenge that, literally in the moment while somebody's eating. So that does occur at higher level eating disorder treatment programs. If you're more in like an inpatient, or I'm sorry, an outpatient setting, which is again least restrictive, you're talking with the client about doing things really slowly. Okay, if we want to get rid of this cutting things into 8, can you cut it into 7, and then process that? Can you do 6? Like, we're not saying, just stop doing this. That doesn't work. We know that doesn't work. It's that all or nothing. Like, we need to move slowly and progressively to kind of get rid of these things, all the while really processing, what is the fear? What do you think will happen if you do this thing? And like, let's let it play out. And let's see what actually happens. It's a lot of cognitive processing, cognitive restructuring, challenging, all of that stuff, and really working with the client, because the reason they're not doing it is because there's a fear there. Their fear of getting rid of it is extremely strong. So you got to work through that.
Got it. So when we're talking about these signs that show up, what can, let's say, a friend, a colleague, a parent is watching this, because I know when you're in the midst of it your own self, you know what's going on, but you can't come to grips with that. So I'm respectful of that. So what kind of signs and symptoms, if we're talking about anorexia and bulimia, other than we see this person vomiting all the time, what other signs and symptoms can we share that says, hey, you know what, take a look at that behavior, we might have to have a conversation?
Yeah. I'll start with body image. I think that's an important place to start. If a loved one or a friend of yours, you're noticing that they're so preoccupied with the way that they look, the way others see them, in terms of their body or, again, looks, that's a big one to start with. Now, again, being concerned about, your body image is not an eating disorder necessarily, but it's oftentimes the very first thing that happens is, I don't like the way that I look. I'm seeing all of these people on social media who don't look like me and are getting all this attention. So I need to change myself. So that's a lot of the times where it starts. And so then starts the food manipulation. It starts either the restriction or the binging, purging cycle and stuff like that. So people should be looking out for the people they care about and whether or not they feel like they're preoccupied with how they look first. And then there's sort of these other symptoms, like I brought up before, the food ritual stuff. If you're noticing somebody doing something that you would consider odd, with their food, or they're constantly skipping out on these dinners, with you, or they're going to these dinners, but they're only eating an appetizer when they typically would order an entree. Like, again, small things here or there. You're wanting to see if you're noticing changes in what a person's doing, how they see themselves, what they're eating, what they're not eating. Are they avoiding these situations? I think that's the place to start. And then, eventually as things get more severe, you might start seeing these other things that I mentioned before, like the way they cut their food, or, them telling you, I'm no longer eating XYZ because it's not healthy, or I need to go to the gym now twice a day because I ate so much the day before. Like, then those things are going to start to come in later.
Gotcha. So, when I look at these eating disorders, and I begin to wonder, and you and I briefly discussed this on that last session, and we can talk about this again, is like, well, as the United States of America, as America in these eating disorders, where are we compared to other countries in eating disorders? Is it just us? I mean, if you go to places where, my God, they're not getting food, they're not having these food disorders. The food disorders, like, there's no food, right? So that's an issue. So the question is, like, where are we as America compared to other countries in eating disorders?
Yeah. I'm glad you brought that up, because I read an article the other day that I believe it was India maybe and Japan were actually rated higher than the US in terms of their prevalence of eating disorders.
For eating disorders,
Yes.
higher than wow.
Yeah, which I found was really interesting too. However, a lot of this goes back to the sort of westernization and stuff like that, and people's access to social media and like the internet and like all of these things out there, all these things that enforce the way or take a look at the way you look, and things are judged like that. So that was really interesting to me, is that we were actually not rated the highest in this particular article, and I don't remember exactly what the year of the article was, but there's something to be said. Like, other countries are really, really struggling with this too, and the majority of them, like I said, are these larger countries with access to the same things that we have. Germany was up there, Russia was up there. I mean, a lot of these sort of larger countries are up there because they have, they have the access.
So again, with more convenience comes more consequence.
Right.
And,
Right.
Gotcha. I want to be respectful of your time. I know you got meetings coming up. So a couple more questions. How does somebody get the opportunity to work with you? How can they work with you?
Yeah. So if you visit Hope Stream Counseling, and I'll kind of spell that for you, it's HOPE Stream, STREAM, counseling.com. We are a private practice, and if you'd like to work with me or any of our clinicians, you can visit our website. And there's a way where you can do a free 15-minute consultation with any of the three of us. So that way we can ensure a good fit. That would be the easiest way to reach out and to contact us. So visit our website. I would be happy to have a consultation with anybody who, would be interested in working with me.
Fantastic. And can you share what it's like in the first session? So someone comes to see you for the first time, because some people, I think they're still apprehensive. I think mental health counseling is so super important. I think everybody and their uncle should undergo this. I wish I could stick a counselor in every office that I'm at. So what is it like, first time to somebody to come with you and like, hey, I'm not going to say anything. The gotchas are all crunched up and I'm not telling them anything. And what happened when I was a kid doesn't matter, but it does. So what's that first session like?
Yeah. The first session is really like getting to know really each other. I like to sort of, I can answer questions about my experience, so they get to know a little bit about me. But then I'm getting to know them. Like, I want to ask questions, not just about what may be considered the problem, but like, let me find out about your support system. Let me find out about, your history of anything. So really the first session is just a lot of asking questions, a lot of sort of finding out more about the client and, explaining how I do things and explaining how therapy goes. Therapy might look different for different people. It's based on what that person's goals are, what they want to work on, and all of that. So we discuss that, like, what are your goals for yourself? What do you want to improve? And then, I do a lot of listening. I think it's important for the person to have that safe space where, if they want to talk about the difficult things, they can. If they don't right away, they don't have to. It's all about the client's experience and what they need at the moment and sort of meeting them where they're at.
Gotcha. Did you ever fire a client? Did you ever like, I'm not doing this anymore?
Yeah, in the sense of like, if a client needs more than what I can offer, like I said, with eating disorders, it's a really slippery slope. If you're working with somebody who, is starting to get some of these medical symptoms that are concerning, or they dropped a significant amount of weight and the interventions you're using with them are not working, then you have to step them up to a higher level of care. So in that sense, technically I've stepped them up, and they're no longer in my care because they need something more. And that's an important thing to talk to people about in the first session, that like, I may have to do this if things get bad, and being very transparent and upfront that it wouldn't be me abandoning you. It's me assessing what you need and making the decision for your welfare, basically, to sort of move you into a treatment modality that you would have a little bit more support.
Beautiful. And one last question is, what book are you reading now?
Yeah. So the last time, if anybody on here was listening the last time, I brought up a book that I was really interested in reading, and it's called Please Eat. And it's by Bev Maddox. And I actually read that book between the time that we met last and today. And it's like, it is such a great book that emphasizes eating disorders in males. So basically this mom, and I won't give away, the whole story, but But the basis around it is this mom is concerned because she starts to see anorexia symptoms in her son, who's an athlete, who's young in high school. And it's a really tough one to read, but it is, I feel like, so important because a lot of the times males are just overlooked. Like, people don't treat males, or, it's just not something that, society might not be as focused on. But what we know is that that's not true now. The way it is now, like the focus on how a man looks, it is a lot. That gym culture, like you have to look like this, you have to do this, like it's a lot. And there's also sports out there like wrestling where you have to meet a certain weight, so you're trying to drop pounds really quickly. So so long story short, it's a really tough one to read because it's a mother's account of what's happening in the moment. But I'd recommend it to anybody that wants to learn a little bit more about how this might look in a boy.
That's excellent. Yeah. Again, we're just giving we're giving a different message, right? And it's a different message than you as females get. We're still getting, you have to look like, part of that gym culture, and you also got, you look at, we have like up on 309, Route 309. It's like, if you buy her the diamond ring, she will love you.
Right.
All right. So I gotta have 6-pack abs, and I gotta have 6 figures income, right? So and that's the message that we're often given. So thank you very much for today. I really appreciate you coming back and doing this again. I'm glad there was no sound feedback. That was really cool. And more time, if you can just share how somebody can get in touch with you, that'd be great.
Yeah, absolutely. And thank you so much for having me. I thought it was a great conversation. And you can contact me through our website. It's www.hopestreamcounseling.com. There's a way to request a consult there. And you can also see our email address there. And feel free to reach out.
Super. Thank you again. All right, everybody. This is
Thanks
Dr.
so much.
Kaye from the Center for Functional Health. Thank you for joining us, and we'll see you soon.